medicine in Liverpool with Professor Squire, a tropical medicine physician. And interestingly, the tropical medicine people also get quite a lot of referrals for persons who have delusional infestation. So they come from not just dermatology, but they come from the tropical medicine route as well. And what I want to do now is to use a little bit of time to just introduce delusional infestation and then focus on a number of recent developments. And I hope that at the end of that you can be a bit more chilled when these patients come in, because you will hopefully have some more solutions of what to do. This one? So starting off with the definition, as you probably know, with delusional infestation, we have people who come to us and they absolutely very strongly believe that they're infested with either living or non-living pathogens that give them certain symptoms, but there is no medical evidence for those symptoms. So we can have various type of symptoms, from itching to there are things coming out of my skin, and also people describe that they feel that they are infested and their nose are full of parasites and that they can feel them, they start to scratch. Sometimes this creates superimposed skin infections, which they will then use to say, look, I told you there's something wrong with the skin, evidence. And the primary thing that they all have in common is that they're absolutely convinced, with usually a high degree of delusional intensity, that they are infested by something. And in the last sort of 20 years, we have the emergence of people who believe they are infested with non-living pathogens, like little threads or fibers or things like that. And that is now something we more commonly see. But it's all part of the same primary problem, which is that they have a primary delusion. Delusional infestation can be primary or secondary, and if it's primary, it's a de novo mental illness. So it's a de novo monodelusion that has occurred out of nothing. Sometimes it's triggered by various events. For example, sometimes it can be triggered by real infections that people might have, or infestation of the house that might bother them. But sometimes they can be associated with other itching sensations, or particularly commonly with changes on the skin. And that is something that we see quite regularly. Secondary are a number of things, and I'll get into that with another slide. But before that, I wanted to name types that we see with delusional infestation, and they also with other monodelusional disorders. But the first one is the shared delusion. So you can have an inducer who's the primary delusion, but they also make sure that others in their family or their immediate environment share that delusional belief. We see that with other monodelusional disorders. Then it can be by proxy, which is a particularly difficult thing to deal with, and that is usually when the person who has the illness believes that either their child or their pet are infested. And particularly when they bring a child, that might create child protection issues, because people try all sorts of things to get rid of what they call the pest or the problem. They might be able to, for example, use bleach on their skin. They may do things like trying to carve out the alleged pathogen out of their skin. All of this is serious self-inflicted damage. And when it's done to a child, and we've had people who bathe their children in bleach, then it can become a really big issue for child protection. The last thing is double DI, And that is when you have a proxy, like a pet, for example, or a very young child, who is not able to tell you whether they actually have symptoms or not. And the double DI is when the inducer believes that they have symptoms themselves, and the proxy has also got symptoms. But the proxy can't tell us, so we don't know whether it's a shared delusion or not, because the proxy can't express themselves. So that's what we termed double DI, or double delusion infestation. Previous names were delusional parasitosis. In the first publication by Ekbom, he called it Dermatozonenwahn, and it was later then called Ekbom syndrome, after the Swedish psychiatrist Ekbom, who first called it Dermatozonenwahn in 1926, I think, but I could be wrong. But the reason why we now call it delusional infestation is because people don't actually think anymore that it's a parasite that has infected them. Parasites are only about 15% of the alleged pathogen that is now being named. So we believe that it's more useful to actually call it delusional infestation, because the infestation is the primary delusional problem. And as you psychiatrists will know, delusional themes developed over time. When you look at paranoid people, they used to be worried about the KGB, now they're paranoid about the CIA, and it kind of develops over time. And this is the same with our delusional infestation people. They used to believe that they were bacteria, then parasites, then viruses, and with any development in medicine, a new pathogen was created. And now, of course, we have the advent of the non-living pathogen that people think is infected. This is just a quick overview of the symptoms. What we primarily see is itching or generalized symptoms. Crawling sensations are very common. People believe that they can see, for example, things coming out of their skin, out of their nose, their ears, and you can imagine how distressing that would be if you had that. So this is a short overview of why we think we should now call it delusional infestation, and the main reason is that the pathogen has moved over time. And that is very common with the development of delusional themes. But when you look at the 2010 study, we find that only 77% actually believed there were organic pathogens. The others believed they were non-living pathogens. And only 13% thought parasites were the actual reason for their symptoms. So coming back, my apologies for this, I thought I'd sorted that out. On the right, you can see the secondary delusional infestation classification. And basically, there are three main things that can cause delusional infestation. One is a primary psychiatric illness. Particularly common is dementia, but we also see it in schizophrenia and in major depression. Then we have all sorts of medical illnesses that have been associated with delusional infestation, particularly those that can cause itching. And we have a variety of brain disorders, patients after strokes. We have paresthesia causing illnesses like diabetes, for example, or jaundice causing illnesses like various cancers. Then we have anything that is induced by substances, and they can be prescribed or non-prescribed. Particularly common are any kind of stimulants, whether they're prescribed as in ADHD medication or non-prescribed as in cocaine, for example. And cocaine and crack cocaine are actually really common causes of delusional infestation. So Patrick and I, for example, in our clinics, we would always try and get a urine sample and check it for use of drugs. And we've published a paper as well that shows that the prevalence of drug use in our patients, in the patient group of delusion infestation, is much higher. It's actually double the size of the drug use in the normal population. So always bear in mind that the patient might be taking cocaine. However, we also have antibiotics, and particularly macrolide antibiotics. And I've had a patient myself that got delusion infestation after starting erythromycin. And after the erythromycin was stopped, within days the delusion infestation symptoms had completely disappeared. There are long lists of medications that have been described in case reviews. We have published those in a 2007 paper that is rather lengthy, but the aim was to actually summarize everything known by that time about the subject, so you can get that free on the internet. So the next part, I think, is about the more recent developments. And one of the recent developments is that there has been a small group of people in the United States who claimed that they had found a new disease, which they called Morgellons disease, which was first named in 2002. And the problem with this is that there is absolutely no evidence for this thing Morgellons. But it's been floating around in some of the literature. When you actually go back, you find that there was only a handful of people who've ever published on this, and they've published always the same cases. And I'm not quite sure why the medical fraternity was so happy to take this up. But there was finally a good study done by the CFC in the United States when there was a claim that it might be related to Lyme's disease. And basically they had almost 150 patients with self-declared Morgellons. They were all investigated fully and to the hilt. And the outcome was there was no Lyme's disease and they had delusional infestation. So if anything, Morgellons is an invented construct that is actually a subtype of delusional infestation where people believe they're infested with non-living pathogens. But we don't use that at all. I really don't encourage the use of it because it is almost pseudo-medicine, and it's something that I don't think will be of any use. Now, we've also seen, as you can see here, that what people find in the skin when we actually investigate what people come with, then we find we get dead skin particles and skin debris, and that is what people bring to us, and they think that it looks like some kind of pathogen. This is another study that suggests that this is looking at how many people bring in specimens. And we always encourage that if that's the case, try and investigate what it is. And try to get the lab to not just tell you it's not a bug or it's not a parasite. Try to make them tell you what it actually is that they could see. So that you can say to the patient, what you believe was this is actually skin debris. Because if all you have on the result is no parasites, the patient will just say, oh, I don't believe that. And you miss the parasite in the lab. But if you get a result of what it really was, you have a persuading the patient to engage. Now I want to come to some of the newest research, and in the interest of time, I'll keep to the main headlines rather than go into the details of the studies. But obviously, please look them up if you have a chance. You can also email me and I can send you the full studies. So this is one that we did twice. because we first looked at this and then we had a bigger sample. And this was done with patients from the UK and Italy and Russia, and Dimitri was part of that, so was Eric. And what we found was that the longer the duration of untreated psychosis is, the worse is the outcome. Now that may not be surprising to any of us, because we know it for schizophrenia, for bipolar affective disorder, but for delusional infestation, we had to prove it because no one actually knew what the situation was. So we can now say that you have the best chance of recovery if you present within a year. If you present after 5 years, that prognosis worsens. However, the good news is, even those who have had the symptoms for more than 10 years still had a reasonable chance of recovery. It just wasn't as good as the ones who only had it for a year or two. This is another study that has just been published, and this is maybe, I would say, possibly one of the most important studies that we have done in the last few years, because we looked at an enormously large number of patients, and you probably know it's virtually impossible trials with these patients, because you would have to tell them they have delusional infestation and then they run away. So we looked at people from the clinics in Liverpool and London, and there were almost 500 people that we'd seen over the years. And we looked at which medications were most likely to give. And there was a clear winner, and the winner was tam-tam, amisulpride, followed by risperidone, and then there were 3 other medications that were much lower, a little bit of effect, but not much, and they were aripiprazole, quetiapine, and olanzapine. So those were the 5 that we used, so they were the 5 we tested. There was a clear winner. So from my point of view, if possible, try and use amisulpride as a first-line treatment, with risperidone as a second-line treatment, because that is where the evidence at the moment leads us. I'll skip the details, but these are the results. So you can see that with amisulpride we get almost 70% response and remission, and we have risperidone with 57%, and then you can see quetiapine, aripiprazole, and olanzapine far lower down, first 2 and the other 3. So I wanted to just mention the outcomes from our clinics in London and Liverpool, and again I'll just go over the brief headings. You'll see it first. No one else other than the authors have seen this data. So when we have a clinic where we either have a dermatologist and a psychiatrist, or we have a tropical school physician and a psychiatrist, the outcomes are this. 12% never turned up, missing data, so we couldn't actually analyze them. 32% were followed up and had a planned discharge, so they were properly discharged to other services, usually psychiatric services or the GP. 41% were lost to follow-up at some point. This doesn't mean that they weren't seen, it just means that they may have been seen 3, 4, 5 times, stopped turning up, and then 13% attended only once. Now 60% attended the clinics at least twice, and of those people who attended at least twice, you can see that 38% had a response and 25% had remission. So that is roughly the outcomes. And when you look at it here, you can see the mean CGIS differences, which is a score that we use to measure outcome. Oops, didn't want to do that. And you can see that those people who had a planned follow-up and were taking medication, a reduction of 2 in a CGI scale that is only from 1 to 7 is a very significant outcome. So it's very good for the patient. But you can see that those who didn't take medication or those who were lost to follow-up had much worse outcomes. Reasonable outcomes, but the best was by far the people that engaged with the clinic and took their medication. We also found that actually those who were the illest at the beginning had the highest improvement. So we shouldn't think that the illest patients are the ones that we can't treat anyway because they're so ill. Actually, our data shows that the illest patients at baseline had the best improvement. So as a conclusion, we can be very clear: if you have delusion infestation, patients get better if they engage with the clinic and they take their medication. So antipsychotics works, and that's a very clear message from this research and from the recent papers that we published. These are just the tips at the end for you when you have patients like that. You do have relatively high aggregate success. You can help these patients. Rapport and engagement are essential. Don't get into a fight with them, but try to work on what you have in common. And if you have in common that you want to help the patient with their symptoms, regardless of the reason for the symptoms, then that is what you could focus on to get away from the arguments about the actual origin of the symptoms. So focus on reducing the symptoms rather than what's causing them. We do examine all specimens that they bring within reason, of course. Sometimes they have whole bags, but then we say, please tell us the one you think is most likely to show us. And it can be very useful to actually have dermatological treatments, particularly because dermatological problems are common. Either because people use bleach on their skin or they scratch a lot and get super infections, but also just to tell them that you are doing something for the skin directly. It's important for dermatologists, I think, to get psychiatric help, but the person who the patient has trust to should be the person who actually starts the treatment, because trust is the most important element that makes the patient engage. Don't forget, the patient thinks they're not ill with a psychiatric illness. So we've covered that, and this is just the last slide about what we can actually do with those patients. So we do think that there's an advantage in building up these psychodermatological clinics. We do think it's an advantage to have psychiatrists work with others to try in the treatment. So I hope that's helped a little bit, and I've given you some of the newest research results that we have available.
Thank you, Dr. Peter. Our distress in terms of treating this entity have been covered up. And I'm sure he also meant, like, though he talked a lot about the